So thank y'all so much for joining us. I'm Jonathan Kaplan. I'm a plastic surgeon in San Francisco, and a big thank you to the to ASAPS, the Aesthetic Society, for co-hosting this webinar with me. The No Surprises Act, it's really got a lot to do with the membership, the aesthetics membership, and so it's great that they understood that how much of an impact it's going to have on their membership. So I'm glad we're going to be able to do that for you today and explain the ins and outs of the No Surprises Act. And also very happy to have, before I introduce our panelists, I want to encourage you to please ask questions. If you look at the panel over on the right-hand side of your screen, you can ask questions as often as you want throughout the webcast, and we'll get to all of those questions at the end. So please, please, please ask questions. A lot of information out there about the No Surprises Act that people are still curious about. And now I'd like to introduce Bob Aker. He is the General Counsel at the American Society of Aesthetic Plastic Surgery. And Bob, why don't you tell us all about yourself?
Well, let's see here. I've been with the Society for 33 years, 9 with former General Counsel, 24 as General Counsel. Those previous 9, I was also counsel to the California Society of Plastic Surgeons, ISAPS. I also, when I was living in Sonoma, was president of the hospital board, the health center board. You know, once you volunteer for one thing, you just really can't say no. And I'm also an Eagle Scout. So I'm happy to go ahead and share with all of you what my take on the No Surprises Act. And despite their best efforts, I think it was terribly crafted. And I wouldn't be surprised to see more than just the few lawsuits we'll talk about as part of the presentation later on.
Well, I'm excited to hear your insights, and I have to say I'm maybe most impressed about the fact that you're an Eagle Scout. That's not something, anybody can be an attorney, anybody can be general counsel, but not everybody can be an Eagle Scout. Continue. Again, I'm Jonathan Kaplan. I introduced myself a little bit earlier. I'm a plastic surgeon in San Francisco. I'm also the founder CEO of BuildMyHealth, a price transparency lead generation platform that is also No Surprises Act compliant. Today's audience, we have a really incredible number of people who've already joined. And for those of you who aren't here yet, we will have it all recorded. You'll get an email with the recording. So please pass this along to anybody you know that is not available once you get that recording, that is not able to be present. But for those of you that are here today, we have a good mix. We have some plastic surgeons that are aesthetic cash pay only. Others of you are insurance-based. Some of you are a hybrid of that. Some of you are in a multi-specialty group where there's aesthetics and insurance. So I ask that while I'm talking about something that maybe is mostly focused on aesthetics, that if you're curious about the insurance, I promise I will get to the insurance side of things, and vice versa. If you're interested in the insurance, and we will get to all of that, aesthetics and the insurance side. It's all very important, and it all is involved in the No Surprises Act. It was passed in December of 2020 as part of a bigger COVID relief bill. And I think the thing most people think about this act is that it mostly deals with surprise bills after an emergency situation. And it does, and we'll get to that. But I have not seen in my lifetime a legislation, healthcare legislation, that affects our lives as plastic surgeons, or all types of specialties, affects our lives and our practice on a daily basis. I don't feel like the Affordable Care Act has as much impact on our daily routine and our practice as this does. I don't feel like HIPAA compliant, or the HIPAA laws back in the late 90s when they came out, I don't think that had any effect as much of it as this does. So I'm not trying to sound hyperbolic that this is like the biggest thing, but I think you will see as I go through it, you'll realize that this is not just something that you can put in your rearview mirror and it's no big deal. This really does affect you and your staff on a daily basis, even if you're purely cash pay. That's another thing. I've never really seen a bill that affects aesthetic surgeons as much as this does, at least it's the way it's intended.
And it probably even shouldn't. It probably shouldn't. You know, when you look at how the act was actually drafted, they never mentioned cosmetic or the word aesthetic. Instead,
correct.
You know, 37 times they say medically necessary. 1,500 times they refer to the word plan, as in medical plans. It's kind of like they were trying to turn themselves from a medical oversight organization into the Consumer Protection Bureau over on the aesthetics, dragging them in. So We'll talk more about that, but I agree. We shouldn't be here.
And thanks for clarifying that. I used the word intended, and this was not their intent, but this is how it seems to be settling out. I agree, it was definitely not their intent. But it is the law of the land since this past January 1st. So if it's something you're thinking that's coming down the road and you'll be able to address it in the future, we're really sort of all non-compliant to some extent. But it does not apply to, the No Surprises Act does not apply to your Medicare patients or Medicaid patients or any other federal programs. Those already have surprise billing statutes in place, so it doesn't apply to those patients. But there are some aspects of this law that applies to doctors that are providing out-of-network care, uninsured care, self-pay, which we're going to talk about as cosmetic in this instance. And some parts of it apply to everyone. And I wanted to start with the parts that apply to everyone, whether you're a med spa, plastic surgeon, primary care doctor. All of us, all providers have to post public disclosure requirements at your front desk where people check in for appointments or whether they schedule procedures or pay bills at that location in your office. If you have multiple offices, you have to put it at the front desk in all those locations. But there's two notices you have to post. One is the standard notice regarding patient protections against surprise billing. The other notice is the right to receive a good faith estimate. So you have to have both of those physically posted by the front desk. You also have to have them posted on the home page of your website. You don't necessarily have to have the whole notice on your homepage of your website. That obviously would be pretty obtrusive, but you at least have to have a link on the homepage of your website. And if you look at my website, PacificHeightsPlasticSurgery.com, you'll see towards the bottom of the homepage 2 links that go to each of these notices. And if you want a copy of the notice, you can email me at drkaplan@ph-ps.com, the email address on the screen, and I'll be happy to email those notices to you. But again, you have to put them at the front desk, sort of like how those patient protections, as far as like the patient bill of rights, those types of things at the front desk. This also needs to belong there. Now, the overarching goal of the No Surprises Act is basically they're trying to avoid patients getting surprise bills after the fact. Doesn't mean you can't send them bills. They don't want them to be surprise bills. So one of the ways they can avoid surprise bills is informing of the costs ahead of time. And this is one of the things that's really surprising to me about the act, is that how much price transparency factors into it. It's really all about telling how much patients they're going to owe ahead of time, whether they're going with cash pay services or insurance-based services. So that's the idea behind the No Surprises Act. And they do this, they implement this by focusing on 2 groups. They want to reduce surprise bills for those patients that are using insurance, and reducing surprise bills for those patients that are not using insurance. And I find that it's easy to understand the act a little bit better when you think of it in these 2 parts, because the regulations differ if you're addressing patients with insurance or not using insurance. The estimates differ, the disclaimers and the consents differ. So there's a lot of nuances that are really different if you look at it in this concept of separating it out into these 2 parts. So let's start with the idea of reducing surprise bills when patients are using insurance. How do you address that? And how does the No Surprises Act affect those patients? So let's assume it's a patient who is on their bike, they fall, they hurt their arm, they have an ambulance, takes them to the ER. The ER doctor sees them, sends them to radiology, gets an x-ray, shows they have a broken arm. The ER doctor splints their arm, sends them home to follow up with an orthopedic surgeon. And then over the next several weeks to months, they start to get some bills. They get a bill from the ER doctor that appears to be in network, and they still have to do their cost sharing. They still have to pay their part of their deductible, their out-of-pocket maximum, their co-insurance. But they see that most of it's covered for the ER doctor's bill. The hospital's bill, as far as the x-ray, that's covered by their in-network benefits. But then they notice that the radiologist who read the x-ray and the ambulance that brought them to the hospital were considered out of network, so they have a much higher bill. And if they have out-of-network benefits, then they still will get some coverage from their insurance company, but with out-of-network benefits, typically your deductible's higher, your out-of-pocket maximum's higher, your co-insurance is higher. And if you don't have out-of-network benefits, then you're on the hook for the entire radiologist bill and the ambulance bill. Now with the No Surprises Act, that radiology bill, they will no longer be able to send you an out-of-network bill in that emergency situation. They'll have to submit a bill for the in-network rate. What is their in-network rate if they're out of network? Well, we'll get to that in a second. It's a long story. We'll get to it though. So the radiologist in this case can only send an in-network rate for that emergency situation. The ambulance, on the other hand, they are actually exempt from the No Surprises Act. The idea behind this was that when Congress was working on the act and they wanted to apply this to ground ambulance companies, they realized that many of them were agencies owned by the city or county in which they worked. And so it was a little bit more convoluted from the perspective of Congress writing a law to impose these laws on an agency of a city or a county. So they just tabled it and they said, well, you know what, we'll address that in the future. So for now, ambulance services, at least ground ambulance services, are not part of the No Surprises Act, so they can continue to send out-of-network bills. Now, why do people send out-of-network bills? Why do they stay out-of-network? It's because they potentially can get higher reimbursement and get paid what they're worth for their expertise. Doctors in emergency situations no longer have this opportunity, but in emergency situations, the ground ambulance can still bill out-of-network, get higher reimbursement, and on top of that, remember that they are an agency of the city or county in which they work, so they're also getting tax revenue. So it's very frustrating that this doesn't apply to the ground ambulance companies and they essentially can double dip. Now, the other way the No Surprises Act is affecting patients with insurance is that if you are a patient, let's say take a woman goes into an in-network hospital to have her baby delivered by an in-network OBGYN, her in-network benefits of course cover that, but then the anesthesiologist that puts in her epidural is out of network. He or she can no longer send that patient an out-of-network bill. They can only send the in-network rate. What's the in-network rate? Again, we'll get to that. But the No Surprises Act outlaws that anesthesiologist, that non-participating provider from sending a surprise bill, an out-of-network bill, in a non-emergency situation. So does that mean you can never send an out-of-network bill in a non-emergency situation? No, luckily there are exceptions. And one of the exceptions absolutely applies to plastic surgeons who are maybe they're doing breast reconstruction and they're out of network. You can still send an out-of-network bill with an out-of-network rate to a patient in a non-emergency situation as long as you provide them with a consent form. And this is a part of the consent form that the Center for Medicare and Medicaid Services has developed. CMS actually drew up this consent. This is the consent form you're supposed to use. And if you read just the top part of this, it says things like, don't sign this bill. You're giving up your rights if you sign this bill to out-of-network payment, to surprise protections. If you sign this, you're going to get a higher bill. That's what the consent says. So you can have the patient sign this legally, and you'll be able to send them an out-of-network bill. However, it doesn't just stop there. You also have to provide them with an estimate of their potential out-of-pocket expenses if you're out of network. That doesn't mean you can just say, oh, my out-of-network bill is $20,000 for this type of breast reconstruction. You can't just give them that number. You also have to then make sure that, see if they have out-of-network benefits, and then tell them what their deductible is, what their out-of-pocket maximum is, what their co-insurance is for those out-of-network benefits. Then you have to tell them how much they've put towards that already in the calendar year so that they know what their out-of-pocket cost sharing will be. So that's a pretty high hurdle to overcome, that you have to, one, make sure they have benefits, and then tell them what they're actually going to pay out of pocket after you factor in all of that cost sharing in your bill. If they don't have out-of-network benefits, you can still send them a bill. You just have to let them know that they're going to owe all of it out of pocket since they don't have out-of-network benefits. Now, so that's an exception to the No Surprises Act, where you can send an out-of-network bill in a non-emergency situation. But then there are exceptions to the exceptions, that when it comes to ancillary services, that an ER doctor, anesthesiologist, neonatologist, radiology, or lab, or pathologist, even if it's a non-emergency situation, they can't go to the patient and have them sign the consent saying, we'd like to send you an out-of-network bill for your lab results. That's not allowed. The No Surprises Act does not allow you to, if you are part of these ancillary services, or an assistant surgeon, intensivist, hospitalist, that you're not allowed to get, even when you get consent, you can still not bill them out of network in a non-emergency situation. Now, Bob, I wanted to get your input on the availability of in-network providers. There is some aspect of the No Surprises Act that says that if there's nobody in network in your area that's providing your service, then you're not allowed to send them an out-of-network bill. Is that your understanding of it?
When you're leaning over the patient and saying, you'd really rather have my services than that guy over there, right? Your ability to go ahead and get that requires, yes, the consent. They have to actually be in a position where they can give consent, but that's not new. Our members have always been concerned about can the patient actually give consent for this particular procedure. Even if they do give consent, however, they have the right to revoke, which is, oh man, up until the procedure itself, really inconvenient. And of course, you can't strong arm them into signing if you are the only provider in town. Now, I guess where this might come back to bite you is if there's one other provider who's in network and the patient says, yeah, I want to use them. But on the other hand, you went ahead and spilled champagne on your colleague's wife at the last fundraiser. So when the hospital calls him, he says, no, I'm not available. He's going to stick it to you, so you're stuck with the in-network rate. So I guess there's a little side there. Stay on good terms with those who will provide you with coverage so that it can be informed consent. When the patient says, yeah, I'd rather have you, there actually is somebody else that they can choose if they want to.
And that's the bottom line, is that the patient has to have an actual choice. That's why an anesthesiologist can't get consent, because you don't really usually have a choice of anesthesiologist when you go in. And if there's no other in-network provider, then you really don't have a choice of that patient. There's no other in-network provider, then you don't really have a choice of choosing to go to that out-of-network provider. That's the only person available. So the other thing that I want to get into, and this is where Bob's really going to give us some more input, and I want to also talk about kind of the background here, is restricting the payment to the in-network rate. So if you can't bill out of network, it's because it's an emergency situation or because you don't get consent, then you can only bill the in-network rate. So the background is that how do they decide on what the in-network rate is? So Congress had decided that if you were going to have to bill the in-network rate, then they can choose from a few different factors. Some of those factors are the median in-network rate. That was one possibility, one variable that you can factor into that, the median in-network rate from that particular insurance company. The other option is that you can look at what that doctor has been reimbursed for before, not what they charge, but what they've been reimbursed for before. You can also factor in how complex the case was. And so that the idea was that if you go to a dispute resolution, you don't agree with what the insurance company wants to pay you for the in-network rate, then the idea is that the dispute resolution the arbiter would look at those different variables that I just mentioned, the median in-network rate, the complexity, how much you were reimbursed in the past. But then fast forward to when CMS actually wrote these regulations, the issue was that they didn't take all those variables into account. They said, well, we're just going to say it's the median in-network rate. And people were saying that was the insurance company basically putting their finger on the scales in their favor. So now that's the background. And so there was a lot of lawsuits about this, about that the way the regulations were written, that it wasn't part of the intent of Congress. So now, Bob, please give us an update on what the litigation has turned up.
Sure. Well, there have been 6 lawsuits filed, 2 of them combined. One of them said that the entire No Surprises Act was unconstitutional and ought to be tossed out on its ear. That isn't expected to go anywhere. The others were all rapidly progressing, but hat off to the Texas Medical Association for being the first one to file a motion for summary judgment and the first one to win. Now, they won it on 2 grounds. One was that the actual act said that when looking at this individual dispute resolution process between the provider and the payer, that they would look at 6 factors, the median price paid in the past being just one. Instead, when they wrote the act, they disregarded the other 5 and just went for the median price paid, which would really tip the scales towards the payers. And so the fact that the regulations weren't drafted to match the act, that was a win in the Texas lawsuit, which was in the Eastern District of Texas Federal Court. On a second ground, though, the court said that independently of that, the plaintiffs should also win, because the whole idea behind rulemaking is that they give it their best shot. They then put it out there for public comment. They get the comment back, they incorporate it, they give answers to it, and then they redraft the law so that it's the best possible. In this case, the rulemaker said, oh, they were in a hurry. They wanted to get this out before January 1st. They couldn't be bothered, and that what they did was exactly what the act said. And the judge said, no, it wasn't. You were obliged to let the public know, get their input. So on an independent basis, that's also then throughout that section. Now, we have to be clear here that though that this independent dispute resolution process, there are two versions of it. One is for the providers to fight with the issuers, with the payers about how much they're going to get paid. But the second way this applies is on behalf of patients who have been given a good faith estimate that we haven't come to yet, but we'll talk about that, and that the actual charges are more than $400 in higher, so they can initiate the same IDR process. The Texas lawsuit did not mention that. It focused only on the IDR process for providers and for the payers. So since that part now is gone, the judge just extracted those parts from the law. It's equivalent to, for those of you who avoid lawyers like COVID at cocktail parties, the net result here is that Texas pulled the tail off the lizard. The lizard still got legs, and the lizard will regrow this tail. It'll take time, but they will regrow it. So this is a temporary situation, and all the lawsuits realistically are focused only on this one issue. So I don't think lawsuits are going to be stopping the No Surprises Act dead in its track at all. Best we understand it and figure out how to get along with the feds.
Right, and also you kind of alluded to this, that the other parts of the No Surprises Act that maybe you don't like, these lawsuits have nothing to do with that. Those parts that we might not like may be here to stay. And then I will get to the dispute resolution process when it comes to the good faith estimate in patients, and that actually goes back to why it's important to think of the act in two parts: the parts when patients are paying with insurance, and those when they're not using insurance, and that applies to several things. So let's talk about now, make that transition to talking about reducing surprise bills when patients are not using insurance. This is where that good faith estimate comes in. And a lot of people refer to the good faith estimate as being like the estimate you provide a patient with both insurance and when they're not using insurance. And just to kind of make sure we're using the same terminology, when you get consent from a patient to build them out a network and you have to provide them with an estimate, that's not technically the good faith estimate. That's just an estimate you provide them with of what their cost sharing is going to be. And that's for that part of the act. The second part of the act, where it is specifically about patients who are uninsured or choosing not to use their insurance or self-pay, which that gets into whether that means cosmetic or not. In those cases, you have to provide the patient with a good faith estimate, and we'll talk about the dispute resolution process in just a second. But first off, why would somebody choose not to use their insurance? Well, maybe they're getting an MRI at an outpatient radiology facility and the cash price is $350, but if you go through your insurance, the negotiated rate is $1,000, but your deductible is $1,000. You haven't paid anything towards it. So if you go through your insurance, you would end up paying $1,000 for something you just pay cash for $350. So that's when somebody chooses not to use their insurance. And if you look at the good faith estimate, this excerpt that I have here, the good faith estimate disclaimer that you give to the patient, or that they tell you when you should use it, it says it's to use it for patients who are uninsured, but it's also for patients who are not seeking to file a claim with their insurance company. So if you're getting an MRI and you want to pay the cash, you're choosing not to file a claim with your insurance to pay the cash rate. But that's not a cosmetic patient. We obviously understand that patients aren't choosing not to file a claim with their insurance company. They don't have the option of filing a claim with their insurance company because cosmetics is excluded in their policy with their insurance policy. But the problem is
that particular aspect of it, because we have members who have patients come in and they ask for a predetermination letter for the procedure. Insurance company says no, it's not covered, so they go ahead and sign our members' paperwork to do it full bore. They do it, but secretly behind the doctor's back, they keep hammering their insurance company until they relent, and then they say, okay, now it's going to be covered. And now our members get a nastygram saying they have to refund everything that is beyond the covered rate that would have applied had they gotten a different determination letter. So frankly, I kind of hate this part of the act that lumps in the whole concept of individuals who are insured but choose not to use their insurance for this particular procedure. I can just see that being a lot of trouble.
Absolutely. And even though if you look at this, doesn't say, like Bob said earlier, this doesn't say anything about aesthetics. And there's another another additional guidance that CMS sent out in December 21st of 2021, where I think I counted it that they used this terminology of uninsured self-pay 108 times, and or at least it was over 100 times they used that terminology, and they never mentioned aesthetics or cosmetics. But the problem is, legally speaking, because they use the term self-pay, they're saying, well, cosmetic patients pay themselves, so that's sort of the same thing. So as of right now, aesthetics is included. That we have reached out, different organizations have reached out to get additional guidance from CMS, but I feel like it's going to be sort of like asking the teacher if there's any homework, and the teacher's going to say, then CMS is going to say, oh yeah, we weren't really thinking of aesthetics, but yes, we should have, aesthetics should be included in this. So I don't think this is going away. They may change it up a little bit, but I don't think they're going. I mean, Bob, you may have a different vibe, but I don't see them saying that aesthetics is completely exempt from this ever in the future.
I agree, even though aesthetics was never part of the problem. I was looking at the list of specialties that they were really focused on, and it started out with, I mean, they say it almost with a sneer that this was designed to cure injustices foisted upon patients by non-contracted, private equity-owned anesthesia, emergency
Right.
medicine, family practice, and dermatology physician groups. Okay, aesthetics isn't really part of that.
Right.
So I agree they weren't thinking about aesthetics, but we'll have to wait and see whether that actually comes up.
So, well, moving on, if you are providing good faith estimates, which as of right now, legally, you are bound to provide good faith estimates. And I know a lot of you are saying, well, we already provide the patient with a quote. That is true, but there's some different nuances that you need to include with your official good faith estimate. First off, you have to provide the estimate within 1 business day if the procedure is within 3 days. Again, this is cash pay. This is not the insurance part. But there's within 3 days. If it's 10 days away, you have 3 days to give it to them. But no matter what, after the patient requests the good faith estimate, you have to provide it within 3 business days. And going back to what Bob mentioned earlier, that there is a dispute resolution process here, that if after the fact they get a bill that's more than $400 than what the good faith estimate was, then the patient can launch a dispute. But keep in mind, again, if you're using insurance, the dispute resolution process is between the doctor not getting paid enough and the insurance company. And if you're going with the cash pay side of it all, then the dispute resolution part is between the patient and the doctor who they feel overcharged them. So keep that in mind, that there are 2 dispute resolution processes, and they're between 2 different entities.
And since it's normally our members' practice to provide a real contract, I mean, this good faith estimate, one of the things it has to say in it is that this is not a contract. You're not obliged to use this person, but it's not a contract. Well, our members have been using contracts. Those trump good faith estimates any day. But now you have an extra layer of paperwork that you have to give them in addition to the actual contract. So if you want to avoid trouble, just make sure those 2 documents agree that the good faith estimate matches what you are going to put in your actual contract.
And so, well, this gets into the good faith estimate, and the nuances of it is that, again, because it's 2 separate parts of the act, insurance versus cash pay, the estimates are different. So let's take a look at the left-hand side of the page. You're choosing to bill somebody out of network. They sign that consent. Then you have to provide them with an estimate of how much their portion is going to be after the cost sharing, as far as the deductible and all that good stuff. So you have to have on your out-of-network estimate, it's got to have the patient's name, the CPT code, cost for you, the consent, as we talked about, and you are supposed to list other available in-network providers, again, so that they know that they have a choice. Now, the next concept that I want to bring up as far as the out-of-network insurance aspect of the No Surprise Act is the advanced EOB. So EOB is explanation of benefits, and typically the patients get the EOB after the procedure, showing how much their surgeon billed, how much the operating room billed, the hospital billed, how much the anesthesiologist billed, and how much those things were paid for by the insurance company and how much you owe. So that's a typical EOB. But now they're added something as far as when you're dealing with insurance, that they created this advanced EOB. Now, the technological plumbing is not in place yet. You don't have to do this yet. It's not even available to provide. But the idea is that you provide your estimate for your services, only your services at this point. And then you would send that estimate to the insurance company, who's going to take your estimate, and then they're going to look at, I guess, historical rates of how much does the anesthesiologist typically bill for that procedure, how much does the hospital bill for that procedure as far as the OR fees and everything. And then they would send a patient that explanation of benefits before the procedure. That's why it's an advanced EOB. That is not in existence yet, but it is something that's part of the act. I just want you to know about it. So for the insurance-based services, aside from the consent, you do have to tell them, the patient, how much you're going to bill them and how much they're going to have to owe of that based on their cost sharing. So you are responsible for your fee. Now, in contrast to the good faith estimate on the right-hand side of the screen, where it's cash pay aesthetics, the estimate has to have your name, your tax ID number, your NPI number, the CPT code. If it's a cosmetic procedure that doesn't have a CPT code, just leave it blank. And you have to have the cost of your services. You have to have a disclaimer that I'll show you in a second. But it'll be enforced in 2023, but you can go ahead and start doing it now because in a sense you're already doing it. The No Surprises Act introduced the concept of the convening provider. So if it's the insurance side where you're only responsible for your fee, for the good faith estimate, you're responsible for collecting everybody's fee. That's the convening provider. Again, I understand a lot of you are already doing this. When you provide a patient with a cosmetic estimate, it's got your fee, it's got the OR fee schedule or the OR fees, and the anesthesia fee based on their fee schedules. So in a sense, you're already the convening provider collecting those estimates. However, the No Surprises Act wrote the law in the sense that the convening provider is either the provider, the convening provider is either the provider, the doctor, or the facility, or whoever is being asked for the good faith estimate. So you may have, and I've talked to other plastic surgeons about this, that their hospital was saying the hospital was going to be the convening provider, and they wanted all of the doctors' fee schedule. Well, I've actually also talked to some other surgery center organizations, and they don't want to be the convening provider. So the way the law is written, any entity could be the convening provider, especially whoever the patient asks for the estimate. But what I'm trying to convey to you is that you could and should be the convening provider. The reason is that you know that your office staff is going to do the best job of conveying what your fees are. So, and to some extent, you're already doing this. You're already collecting the professional fee, OR fee, and anesthesia fee. If you outsource this to the hospital or the surgery center, you don't know who's providing those fees. And so if they provide a fee on your behalf that's not accurate, that's going to cause some consternation between you and the patient. So that's why I think you should take this on your own. And since you're kind of already doing this, become the convening provider. That way you can make sure you're providing the right estimates for yourself. And it also incentivizes the hospital, the surgery center, to make sure you're provided with the correct fee schedules, the most up-to-date fee schedules, because they don't want you providing a good faith estimate that is not accurate for them either. Now, one of the things I've been asked about before, and I've also inquired about it, is that if you're the convening provider and you provide the patient with a good faith estimate, and then after the fact, the anesthesiologist says, oh, the bill went over, you owe me $600, well, that's over the $400 limit. Am I, as the doctor who put together that estimate, the convening provider, am I liable for that overcharge or that surprise bill by the anesthesiologist? I have an answer. Bob, do you have an answer?
Technically, you're only going to be liable for your part. Yes, you are putting together good faith estimates from others, but they are estimates. And part of the disclaimers in the good faith estimate says these are just estimates. There may be other factors. That could be why the Act also allows patients to go directly to your co-providers and ask them for their own good faith estimate directly. That will put some burden upon anytime you're asked to provide what's your share. Well, keep track of it. You know, it may come back to bite you if you think that, oh yeah, I forgot that I went ahead and promised to do this for X amount of dollars. You can't forget like that. I mean, for the same reason, perhaps, once they get their infrastructure up and you have to start giving prices to the issuers, you've got to update your own estimate of benefit prices every year. So there's no forgetting, I forgot that's how much I was going to charge before. That's what I forgot I told the patient that.
Right.
You don't want all that. You've got to keep good records on that. This is really going to be a pain for everybody. But from a standpoint of consumer protection, it's a great law.
Well, and so if for those of you who are thinking, well, what happens if my cosmetic breast reduction goes over at the surgery center? So keep in mind, this act doesn't forbid you from sending a bill after the fact. They just don't want you to send a surprise bill. So if you think that your breast reduction could take 4 hours, then give the patient the good faith estimate that says it's going to be 4 hours, and the OR and anesthesia fees are going to be based on that 4 hour time frame. And so if it ends up being three, and then maybe you just get payment up front for the 3 hour version of the estimate. And then if it does go over into that 4th hour, then you can send a supplemental bill. It's no longer a surprise bill because they were told ahead of time that was a possibility. So the idea is you can overestimate and maybe collect less, or you can collect the overestimated amount and refund it if you want to after the fact. But the point being is, I just want to drive home the point is that you're not disallowed from sending a bill after the fact as long as you've told the patient how much it could possibly be after the fact, as long as you're telling them that ahead of time.
And I think Congress understood that in order to avoid this eventuality, providers may well be upping their good faith estimates so as to always be under 400 over.
Right. And also keep in mind that if this goes to a dispute resolution process and there was some unexpected event, and that's why you sent a higher bill, that's actually protected in the No Surprises Act. If you can legitimately say this unexpected act occurred, nobody would have expected that to happen, but it did, and that's why I'm sending a bill for this, that's okay, as long as you can substantiate that.
And you don't really want to create crazy high bills just to protect yourself, because patients now will have the right to go to you and every competitor they feel like and pick up a good faith estimate of what your aesthetic procedure is going to cost. And they're going to assume these amounts they've given you are accurate, so they can price shop. So that's sort of what keeps you from being too crazy on overestimating costs.
To some extent, the market forces are starting to apply to healthcare the way they haven't before. So I want to transition here and explain that I understand that we've given you a lot of really heavy duty, some potentially bad news, and a lot of new regulations that you're going to have to implement in the daily routine of your office. So we wanted to go through what some of you are doing to address this manually, things you've already been doing as far as even when you've been the convening provider in the past. We want to talk about things you've been doing manually in the past and things that ways that you can do this in a more automated fashion. Because I know whenever there's new laws or regulations, what we do is we turn around to our office staff and say, hey, here are some additional tasks you have to add to your daily routine. And continuing to just add more and more manual tasks, I'm afraid we're getting to a tipping point where it's not going to be possible, that we're going to have to start to find more automated ways of doing this. And so I'm going to be showing some things that we do in our office in an automated fashion that address some pain points that will be brought on by the No Surprises Act. And so these ideas of automation that I'm providing you with, these are ideas I want you to go back to your electronic health record vendor or your revenue cycle management vendor or your consumer relationship management vendor and see if there's some solutions that they have similar to our solutions for automation that we provide. And you can reach out to me too if you have questions about our solutions. But I just want you to kind of understand that these are going to be pain points that you're going to have to start addressing now. And I want to give you, well, we'll talk about the manual options, but I also want to provide you with some automated options that might make your life easier. The first one is fielding phone calls about price. It's already on TikTok that the doctors are required to give good faith estimates. Now, they might not be providing accurate information on TikTok because a good faith estimate is really typically the patient comes in to see you, you talk to them, and then you, based on seeing them, you can give them a more accurate estimate and they sign that disclaimer. That's technically what a good faith estimate is. Calling up and asking about price isn't technically asking for a good faith estimate, it's just, but it is asking for an estimate. So manually, what do many of you do right now? People call asking about price, and I think people are going to start calling more asking about price because they think they have the right to a good faith estimate. So right now, what are you doing? You're answering the patient over the phone, telling them, well, we can't give you an estimate over the phone until we see you. You have to come in for that. Patients are going to erroneously think that you're refusing to give them a good faith estimate. And even though they may be wrong, they could still write a bad review that you won't provide estimates over the phone. They could report you to the board, which would, again, not be accurate, but it's still a nuisance. So the other option is to provide patients with all the pricing information over the phone. But then the problem is that, what happens after you tell them the price? They hang up and you have no idea who they are. So what we do in our office to automate this process, to make it easier, rather than fighting with them, telling them that we won't give them an estimate, or rather than going through this whole, a script of like explaining to the patients why it's not all about price. It's not all about price. But what we do to automate this process, just to give the patient the answer they want, we do it, but we do it sort of on our terms. So our office staff pulls up their dashboard and you'll see this big blue button to start a new estimate. And our office staff will click on that button and we ask the patient, what's your email address? And maybe if they're already in the system, great. If not, we add it to our system. So we're capturing a lead. But then we want to give them that cash estimate over the phone, and we can actually email it to them. So what we do is we just look through our database of procedures and pricing, and your EHR, your RCM company might have something like this. But we pull up, for example, tummy tuck, and that pulls in the procedure and all of a breakdown of all the pricing. So we're not having to manually do this. They may also ask for another procedure, but we can quickly add procedures and even put a discount on the secondary procedure if that's your routine in your office. And we can email this to the patient. I was reading something yesterday about CMS estimates that to manually make estimates for patients is going to take you over an hour to do it manually. This is meant to be able to do this real time while you're on the phone with the patient and email it to them so they get the price. And at that point, you can ask them if they want to come in for a consultation or not. If they're a price shopper, then you've moved on. At least you got their email address. You can add it to your email marketing database, and maybe eventually they'll come in for something else. So that is one way of handling these calls. And again, talk to your EHR or RCM company or reach out to me to learn more about this. But I think this is an efficient way of handling it. But an even more efficient way is to let the patient know pricing on your website. Now, you could just list a static menu of pricing. That's a manual option. The only downside to that is the way we were capturing a patient's contact information. You can't really do that if you just list your pricing. You don't get a lead out of that. The other problem with this is if you're doing insurance, then you don't really know. It's going to be hard to list all your insurance plans, all your procedures, and patients aren't going to be able to figure out their cost sharing for that. Then an automated option is taking a page out of the playbook from the credit card industry. So if you remember the way it used to be with the credit cards, that you had to, if you went to a drugstore, grocery store, or the doctor's office, or the corner market, you had to give your credit card to the person on the other side of the counter, the employee, because they were the only person who was specially trained and in service to be able to run your credit card. You weren't able to do that. Well, now, fast forward, the credit card companies have given the patient, the consumer, the ability to run their own credit card, and letting the consumer or the patient do that by either Samsung Pay, Apple Pay. So taking that page from the credit card company's playbook, I'm suggesting shifting all of this estimation process to your website. So here's my website, Pacific Heights Plastic Surgery. And one of the ways we do this is with a chatbot. Again, your RCM company might have something similar. Revenue cycle management company may have something similar. But with the chatbot, they can choose their category or choose their insurance plan if they're doing insurance-based pricing. And they can choose the category, choose a procedure. In this case, we'll say breast enlargement and lift with silicone implants. And we get the patient's contact information, their name, email address, phone number, zip code. And then the chatbot automatically sends the patient an email with a breakdown of all the pricing. So they get the answer to their question about how much does it cost. And our office staff doesn't have to bother with it. Our office staff does get the same email, and then we can follow up with the patient because we see their name, email address, and phone number. So that's a nice automated way of addressing questions about pricing through your website. Now, when they come in, you still have the issue of dealing with the additional paperwork. So if it's an insurance-based estimate, you have to have that consent form. If it's a cash-based estimate, you have to have a disclaimer, which I'll show you in a second. So you can just pull that additional paperwork out of the drawer and add it to all of your intake paperwork that you have when the patient comes in. But actually, no, you can't. CMS was so specific in their regulations that they said you can't just add the disclaimer and the out-of-network billing consent form to your intake paperwork. You can't bundle it in. They really went out of their way to say that. You have to keep that paperwork, as far as the disclaimer and the consent, separate and have it attached to the quote or the estimate that you're giving the patient once they come in for a consultation. You can't just combine it. So you just have to remember to pull out that paperwork out of that drawer along with all the other paperwork. But an automated way to handle it is, again, your EHR may already have a solution for this, or your RCM company. And what our office staff does is they go in and find that estimate the patient submitted already. So in that example, it was a breast aug and lift. And we can take that estimate they already submitted, and we can convert that into a good faith estimate, where we have to include several things like their date of birth, their address. We have to include a diagnosis code for that cosmetic procedure, which there is a diagnosis code for cosmetic services. And then we can take that estimate that they've already submitted, and we can then adjust it if necessary. We can send them an updated email. But if they're in the office, we can actually print out the quote for them. This doesn't have to be manual. That includes all the information that's required as part of the CMS regulations, as far as the diagnosis code, CPT code, if there is one, a breakdown of all the pricing, and that disclaimer that CMS says you have to attach to your good faith estimate. So there are ways of doing this in an automated way that it doesn't have to be such a burden on the office. And you are already getting the patient to sign the consents anyway. Now you're getting them to sign the consent that's attached to the disclaimer that CMS says you have to have based on the No Surprises Act regulations. Going back to the idea of the convening provider, right now you may already be creating these quotes for patients, but keep in mind that right now if you go to multiple facilities, there's different OR and anesthesia fee schedules. So your business managers looking at all these spreadsheets and they are trying to do all these calculations. And so in the past, if you were off, maybe the anesthesiologist, the operating room would just send a bill after the fact. Well, now they really can't get away with that. They'll get into some trouble. So you just want to be more accurate in being the convening provider and automating that process rather than just looking at all these different spreadsheets. So one of the things we do is that if we're doing a procedure in our office, then we have a fee schedule associated with that, with the OR and anesthesia fees. If we're doing it at an outpatient surgery center or a separate facility, we have a different fee schedule for that. So if I toggle back and forth, you can see these fees change based on the facility. And so when we provide the patient with a quote, then we are attaching the correct estimate based on that location. So it reduces the risk of us making a mistake. So another reason automation is good, so you avoid giving the patient a quote that may be accurate for yourself, but inaccurate for the anesthesia bill or the OR fee, because if they keep getting to a point where they can't send a bill after the fact because you gave a wrong quote, then they'll be upset with that. But I still think you should be the convening provider. Now, shifting a little bit from the cash pay aspect of it all to the out-of-network benefits, this is something I alluded to earlier, that this is going to be a pretty tall hurdle to overcome, that you can't just give the patient the consent and say we're going to send a bill for this amount. You have to tell them what their cost sharing is. So right now, a lot of you are probably calling the insurance company and waiting on hold, finding out if the patient does even have out-of-network benefits and what their cost sharing responsibility is going to be, or how much they've contributed to their deductible, their out-of-pocket maximum, and their co-insurance for that year. And then you can accurately calculate how much they're going to owe you for that out-of-network bill. Now, there are other real-time eligibility software available, like from your revenue cycle management company and things like that. What we do in our office is same thing. We shift this responsibility to the consumer, and we let them use our price estimator on our website, where the consumer can check the cash rate for something, but then they can also check their insurance rates. And this is where you can't really use a static menu of pricing. In this example, we'll say they have United PPO, and then they look at all the different categories of services. They choose breast, it's a plastic surgery webinar. They can choose the DIEP flat breast reconstruction. Let's say you're out of network for that. And then the consumer can actually put in their deductible and their out-of-pocket maximum and their coinsurance if they know it. Probably they don't know that information, so they can at least put in their member ID number. They have their insurance card and they put in this information. This is the same information your office staff would be calling the insurance company to give. Now you're letting the patient do it, and you're getting the patient's contact information in the process. And so then the patient can see what your negotiated rate is, but then they can also see what you've paid towards, what the patient's paid towards their deductible, their out-of-pocket maximum, their coinsurance. They see what their estimated out-of-pocket cost is, and they see what the insurance company is going to pay. This is technology that's already available. And in addition to that, the patient gets the email with a breakdown of all the pricing. This is beneficial in three ways. One is you're letting the patient figure this out themselves. Your office staff doesn't have to do it, and the patient has a more realistic understanding of the cost. The other thing is when a patient comes in and you ask them for a copay, they're incensed that they have to pay a $40 copay. They may have gotten $300 worth of Botox the other day, but that's not the issue. They just think that I have insurance, I shouldn't have to pay anything. So if they're upset about a $40 copay, then they're probably going to be really upset if you tell them after the consultation, by the way, you owe us $8,300 before we can do that DIEP flap reconstruction. So that's the second thing, is they come in with more realistic understanding that yes, they have insurance, but they still owe out of pocket. The third benefit is after that consultation, when they go talk to the office manager, the business manager, they're less likely to yell at the business manager because they came in knowing that they would owe some money, that it's the first time they're hearing about what they owe should not be at the end of the consultation with the business manager. And then similarly, what my office staff can do is that if the patient checks pricing for that insurance-based service, then we can pull that up once they come in for the consultation. We can pull up that estimate, and we can see that, we can make sure that we have their insurance information and that we've applied the appropriate out-of-network rates. We can make sure that we're compliant with the estimate that we have to give them, which includes their address, and we have to include a diagnosis code, so you can include that for their breast procedure. But then you might see the patient, you see, oh, they're not a candidate for a DIEP, they don't have enough abdominal tissue. Well, this is your opportunity to take that estimate and adjust it and say, you know what, we're going to need to take tissue from the buttocks, and you can then add that to your estimate and remove the DIEP flap that they're not a candidate for. But the benefit of this is that you already have all of their insurance information, and then you can resubmit that for real-time eligibility and see that based on that new procedure, what are their out-of-network benefits and what are they going to owe, what is their cost sharing based on their deductible out-of-pocket maximum coinsurance for that new procedure. So you have the opportunity to adjust those procedures, and then you can provide them with a quote right then and there on the spot, much easier with all of that information that's required by CMS, including the diagnosis code, your tax ID number, MPI number, and it includes all of their cost sharing, which you're required to provide them with. And then there's that surprise billing protection form that CMS says you have to provide to the patient and have them sign it. So there are some automated ways to make this easier for you. Just reach out to some existing vendors, or you can reach out to me at the email address that I give you at the end of the webinar. So this could be potentially painful, but it doesn't have to be, because this can be an opportunity for you to revamp the way you do your office. You can have patients submitting estimates online, and then by the time they come in for the consultation, you can give them that quote that maybe it's the exact quote that they already submitted, or you can adjust it as necessary, and then you can provide them with the quotes based on whether it's an out-of-network estimate that has that consent form, or it's a good faith estimate for a cash pay service, and you have to provide them with a disclaimer, and it's all included. So this is kind of a good way to think about it, is that this may be the focal point of all of your marketing, is that you have cash pay services, you have insurance-based services. The consumer can check those prices now on your website, and you can make this more efficient for your office. I know people are, go ahead.
Jonathan, speaking of uncomfortable, I'm not sure we're giving enough pain to the audience here. If I read it correctly, CMS is intending, once they've got that portal up and running, and that all providers submit their information, to each, it's going to go through CMS out to the various payers, and that the public will be able to price shop online by looking at all the information that our members and all of the doctors are submitting through this new portal. Do you see this level of price transparency? I mean, it's beyond transparency. It's almost, you're actually being proactive and offering it on your website. But do you see this level of price transparency being just the inevitable future, not just for insurance providers, but also for aesthetic providers?
Yeah, I'm going to go off on a few different tangents here. That advanced EOB that you're referring to, that when it's an insurance-based service, that you're going to have to submit that to the insurance company, and then they're going to turn around and send your fee plus the anesthesia fee or what other fees are associated with it. That's something that's not set up yet, but yes, that's going to be the future for insurance-based services. But then on top of that, keep in mind that as of this past January 1st, there's another bill that went into a regulation that went into effect, that insurance companies are supposed to post all of their prices of all of their providers on their website. So remember, in January 1st of 2021, hospitals were required to post all their prices on their website. They're maybe non-compliant to the tune of maybe 16%. I think like 84% of them are non-compliant. But yeah, over a year ago, hospitals were already having to show their pricing on their website. Now insurance companies are going to, the Biden administration says they're going to enforce it starting in July 1st of 2022, this year, where insurance companies have to show all of their prices on for all of their providers, for all of the different procedures, all the different plans on their website. I assume it's going to be a ton of information. It's going to be probably hard to navigate. And so my point being is that price transparency is coming. Just because you put your head in the sand, it's not going away. Everybody else is doing it. The federal government is requiring it. And so I think, yes, it's definitely going to be part of aesthetics. It already is to some extent. Like you said, it's on our website. But I think it's an opportunity to, well, this actually is a great segue to the benefits of price transparency. The next part of the webinar is that you need to think of this as a benefit, not just because you have to do it, or because, and even though you technically don't have to do it for the aesthetics perspective, it obviously is going that direction. Also, I think eventually you're going to have to do it for in-network services. Again, they just started with out-of-network and cash pay because those were the areas people were most likely to get surprise bills. But I think they're going to start requiring you to do this eventually for in-network services and showing the patient what their cost sharing is going to be. And then you're also going to really need to use real-time eligibility for that. But other benefits of it are, we actually wrote a paper about this in a peer-reviewed journal a couple of years ago, where we found that when patients came in and they were price aware, that they were 41% more likely to book a procedure on the spot. And so the idea being is that they weren't struck by sticker shock, that they had a better idea, and ostensibly they were prepared for that price. And so they were 41% more likely to decide to do a procedure. So you have a better chance of moving from the exam room to the operating room. The other benefit is the more data, and this is what I was talking about with the insurance companies, that you'll be able to see how your negotiated rates look on those insurance company websites. The consumer will be able to see that. But then also, because we work with a lot of doctors and we all share our pricing amongst our various providers, that we can actually see how our prices compare to other doctors. The consumer can't really see this, but at least we can see how our prices compare across the country, all the way down to our zip code, for surgical procedures, for lip filler, and things like that. So this is another benefit of price transparency, is that you get a better idea of where you fit within the competitive landscape when you start to crowdsource this kind of pricing information for minimally invasive procedures too. So please email me, and I'll be happy to send you all of these different notices and the consent forms and the disclaimers that are required with these different types of estimates. But you take a quick picture with your phone or a screenshot, but just email me at drkaplan@ph-ps.com. And then I want to conclude with a glass is half full type of analogy. I know this is a lot of information we provided you with, but I hope that you've understood that based on my comparison of manual versus automation, that I think it's just untenable to feel like we can do a lot of this, continue to do this manually. I don't think that's possible with the amount of people that are going to continue to call in for pricing, and then you're going to want to make sure your pricing is accurate as far as the convening provider, that it's accurate for the OR and the anesthesiologist. But use this legislation as an opportunity to improve your workflow by shifting more responsibility to the patient, to your website, for them to check pricing on their own. That reduces the workload on your back office staff. They're not having to do the real-time eligibility for insurance-based services, reduces burnout, and it takes the task that you're already doing. I mean, they're already sitting on the phone with the insurance company, for example, or they're already creating quotes. You're taking those tasks you're already doing, and now you're just using this as an opportunity to make them all more efficient. So thank you all so much for your time. And now we are happy to take some questions, and also you can email me or Bob after the webinar. You'll also be getting an email about this with a video of it. So let me go through. We have a lot of questions. Our plastic surgeons take call at hospitals in our area. They bill independently of the hospital. They see a patient in the emergency setting, and they're uninsured. Can the plastic surgeon bill the uninsured patient for services? So this is a great question. Get this all the time. So consider this situation: if the patient's in the ER and they have insurance or not, if the ER doctor calls you, says the patient requested a plastic surgeon, then it's maybe not so much of an emergency, and so you can come in and see that patient if you want. But let's say they're mentating, they're totally with it. The ER doctor could have sewn it up, but they didn't want the ER doctor. They were with it enough that they demanded a plastic surgeon. So they call you, you're not necessarily on call. If you come in, whether they're insured or not, consider the fact that you could just charge them cash, that it's a good faith estimate whether they're using insurance or not. That way you can get payment up front, and you give them that disclaimer that they're not going to get any surprise billing after the fact. That's if they're with it and they can make that decision. If they're uninsured, you can do the same thing with a good faith estimate. So keep that in mind, that if they're with it, then you can choose whether you want to go to the out-of-network route if that's your situation, if you're not typically taking call, or you can go the cash route if they don't have insurance. You can really make that decision if they're with it. If it's an emergency and they aren't with it, you don't have a choice. You have to provide that service, and you can only bill them an in-network rate. You cannot bill them an out-of-network rate in that situation. Let's see. So I'm gonna. Somebody asked about my email address. You have it right there. I'm happy to send you the disclosures and things like that. So out of this person's out of network, they pay based on refuse to disclose with the US rate. So if you are trying to give a good faith estimate and you work with the facility, they, it's going to be awkward if they try to refuse to give you their fee schedule because you, as the provider, if the patient is asking you for the good faith estimate, you have to provide that good faith estimate. So that facility is violating the act by not cooperating with you. Bob, feel free to jump in if you have any other input on any of these.
Oh, well, I just go ahead and add right to the paperwork you give the patient. This is my estimate. I went ahead and asked them for their estimate. They refused. FYI, if I have no idea what that's going to cost you.
Yeah, they'll quickly. They'll definitely. They'll get in line, I'm sure, as far as the facilities if they're refusing that. So this is saying that this is almost impossible to get from the insurance company. They wanted to tell us about how much we pay for electric. I mean, the insurance, how much you're going to bill the patient, your negotiated rate, that is something, information you already have. As far as what the patient's cost sharing will be, that can be done electronically through real-time eligibility, as I demonstrated. So you, and also how I showed you that we take your negotiated rate and then we subtract out the patient's, how much they've paid towards their deductible, their out-of-pocket maximum, their coinsurance. So that math is done automatically by your revenue cycle management company, or the way I just demonstrated with how we do it in our office. So you can get that information. You have, if you've signed a contract with the patients, with the insurance company, you have those negotiated rates. And if you're out of network, then the rates are kind of whatever you've decided they are. So the question was, is it the requirement for a good faith estimate for non-emergent out-of-network care deferred until 2023? So that's kind of mixing up a few different things. The good faith estimate is only for cash-based services. It has nothing to do with out-of-network services, has nothing to do with non-emergent services either. The estimates that you have to provide for out-of-network services that are non-emergency, that estimate, you have to provide that estimate for yourself now. As far as the advanced DOB with the other providers for those insurance-based services, that's been deferred because they haven't developed it all yet. The other thing that this person may be referring to is that for the good faith estimates for the cash-based services, that you do have to be the convening provider. That has been deferred to 2023, but I was pointing out that you're in essentially you've already been a convening provider all these years for cash-based aesthetic services because you're already giving the patient your fee, the OR fee, and the anesthesia fee. So you can go ahead and get a jump on it now, but correct, it's not going to be enforced for good faith estimates for cash-based aesthetic services until 2023.
Yeah, I think CMS may have clouded the issue a bit because on their website, they give the implication that patients are, whether you're insured or not insured, you're entitled to a good faith estimate. And that's not technically correct. The details aren't going to, for the insured person, the details aren't going to go directly to the patient. They're going to go to the patient's insurance company, which will provide them back to the patient as part of the explanation of benefits.
Correct. Did you say a surgical assistant cannot bill out of network? That is correct. They that was one of, like, as far as anesthesiologists, which is why the anesthesiologists are suing, probably. But anesthesiologists are never allowed to get consent and bill out of network in a non-emergency situation. And then I also listed intensivists, neonatologists, assistants cannot bill out of network across the board in non-emergency situations. Thanks for that question. For the cosmetic patients, the good faith estimate come before or after the consultation? What if someone calls in and asks for a price? So technically, the good faith estimate is if a patient requests it. I would argue that the patient is really just asking for an estimate if they call in. They're not demanding the CMS documented mandated version of a good faith estimate. A good faith estimate, according to the law, is all of these things, including your tax ID number and your NPI number and this disclaimer. The patient who's calling in doesn't care about all that. They just want an estimate. So you don't have to give them the technical good faith estimate, but I do encourage you to give them an estimate. But again, do it on your terms, at least get contact information out of it, and do it in a way that does not grind your office to a halt.
And
So,
if the person's calling for basically a walk-in, if they want services today or tomorrow or the day after tomorrow, you don't have to give them a good faith estimate. You can go ahead and see them and no estimate applies. It's only after that period that you have to give them something.
correct. If you are not seeing out-of-network patients, then we don't have to do these good faith estimates. So if you're seeing in-network patients, this does not apply, but it will eventually. I mean, this was just, they just started without a network and cash pay. But eventually will come to the point where an in-network patient will want to know what their cost sharing is going to be beforehand. But no, it does not apply to in-network at this time, but you can still give them their cost sharing information. And again, good faith estimate, according to the law, is really applying to the cash pay aspect of it. And I only keep reiterating that because it's just easier to have, to try to minimize the confusion if we're all using the same terminology. All right, and then we have a lot of questions. So as long as y'all are willing to stay, and Bob, you have the time, I'm happy to stay too.
Yeah.
Okay, we don't consider a caller a website visitor a patient. So that, there you go. So let's get back to what we were just talking about. It seems like this would only apply to patients who complete paperwork and see a provider. Again, the good faith estimate, yes, if you want to just apply that to patients that come in for a consultation, the good faith estimate, yes, has to apply, abide by those CMS regulations with the disclaimer. But if people are calling and asking you for pricing and you refuse to give them any pricing, they may misconstrue that as you refusing to give them a good faith estimate, even though they're incorrect. And they could write a review and they could report you to the board. I just see that's where this is going because people don't understand the good faith estimate isn't the same as a plain old estimate, which as you've seen, we allow patients to get estimates over our website so they don't take up all the office staff's time asking for estimates if they're tire kickers or price shoppers. Does the NSA apply to non-invasive and minimally invasive services, aesthetic med spa side of multi-specialty offices? Okay, so we'll see what CMS comes out and says about this, but if you're doing a procedure like Botox, I am not providing good faith estimates for that. If it's something that there's really no chance of a surprise bill after the fact, we're not providing good faith estimates for that. We'll let the patient know how much it's going to cost ahead of time verbally. But when it gets into procedures and there's multiple providers, then that's when you're definitely required to have a good faith estimate. The other thing to keep in mind, though, if you start doing laser hair removal and maybe it doesn't work exactly the way you want, and the patient comes back in and they want a touch up, but you want to charge them for that touch up, and maybe that's more than $400, then the patient may say something to you in this non-invasive service that, oh, well, that's a surprise bill. So it's a fine line, or maybe it's a very blurry line. Where for just Botox, I think that's pretty straightforward. You don't need a good faith estimate for that necessarily because there's no surprise bills. Surgical procedures, certainly you need it. Somewhere in the middle, when things get minimally invasive and there may be some subsequent treatment needs, things that could have been foreseeable, you probably do need to provide a good faith estimate for that, even if it's not something that's taking place at a surgery center or in the operating room.
It'll be interesting going forward. Historically, patients have just used chargebacks as their forum for resolving disputes. Well, but their arguments have always been dissatisfaction with the results, not price. Now, by giving good faith estimates and a final estimate, now patients can take those and initiate a chargeback and just claim that the amount that they were promised was not what they actually ended up paying. Technically, the good faith estimate isn't a contract, but nevertheless, it creates expectations. And it'll be interesting to see if that then starts to enter into the chargeback arena, where high school graduates working for Visa and MasterCard get to make the call whether the patient should get a refund or not.
Yeah, chargebacks are going to be the next frontier. That's going to become a bigger and bigger problem. People wanting their money back because they didn't like the result, not realizing that that's not what you were paying for. You were paying for me to do this procedure. I can't guarantee whether you're happy or not after the fact. I can only guarantee I'm going to do this procedure. So yeah, chargebacks are going to become a bigger issue down the road. What software does your office use? Our software is what I disclosed at the beginning. It's a software that I developed. I got into price transparency like 10 years ago when price transparency wasn't cool. May not be cool still, but it's certainly a buzzword now. But that is our software that it's a company that I started. So you're welcome to reach out to me and email me. I'm happy to provide you more information about our platform. How do you ask somebody in the ER to pay you? It's a great question. I've never personally done it, but I know that there are doctors that do that who've asked me this question before. And if the patient is with it and it's not really an emergency situation any longer, that they're totally copacetic, and I know doctors that they would go in with their Square, have it plugged into their phone, and they'd have the patient swipe a credit card. I don't know how to ask a patient to pay in the ER, but if you are worried about treating them as a cash pay patient with a good faith estimate and asking them for cash up front, then you could treat them as an out-of-network patient if it's no longer technically considered an emergency, and you can bill them as an out-of-network provider if it's truly not an emergency. But it's going to be tricky if they're in the emergency room and you're trying to say it's not an emergency. So be careful. Let's see here. Somebody's asking if we already have your platform, can we add those features that we presented? Yes, and it's kind of already included to some extent. I practice in New Jersey. Insurance companies never reveal what their permitted fee schedule is for out-of-network services. They use terms like usual and customary. So again, for in-network services, they're going to be required to post their pricing on their website. For out-of-network services, you are choosing what you want to submit to the insurance company, what you want to charge. Then you can use the real-time eligibility functionality that comes with our platform or with other revenue cycle management platforms, where you can determine what their out-of-pocket maximum, their co-insurance is, and their deductible, and you will be able to see how much they've put towards that. So then you will be able to see how much they will owe towards your bill. Now, if the insurance company only covers a portion of that and there's still some outstanding money, then that's okay. You told them what the cost was going to be ahead of time. You're not sending them you're not sending them a surprise bill after the fact. You are balance billing, but if it's a non-emergency situation, you provided them with that consent, you provided them with their cost sharing, then you've told them what the total amount is. So like say, for example, your total amount is $60,000 and the insurance company only pays 40, and then their cost sharing puts in a little bit, and maybe there's like $5,000 left. You can still send the patient that bill for $5,000 if it's not an emergency, and you disclose the potential cost ahead of time. That is still possible. So even if your insurance company won't tell you some information, you can still provide enough information to the patient that you can collect after the fact in a non-emergency situation for an out-of-network bill if you provided consent and, again, provided them with their cost sharing information. So a lot of caveats there, but it is still possible to do. As an out-of-network provider, how are you able to provide a patient a cost estimate when insurance companies do not provide information? So there you go. So that's the thing. As long as you're telling them what the total potential cost is, you can balance bill in a non-emergency situation, even if the insurance company you feel is not cooperating with you, but you can still give the patient a lot of information in regards to the cost sharing aspect of it. If a patient wants to come to your office, has a laceration, and wants to pay out of pocket, that's totally fine. You just give them a good faith estimate and you charge them what it is, and don't send them a bill after the fact, or certainly not a surprise bill. If you're a cosmetic surgeon,
I suppose if they're just a walk-in, you don't even need to give them a good faith estimate.
That's true. If it's a one and done thing, I agree.
It's a one and done thing.
So what if your cosmetic surgeon quotes by the hour, not the procedure, giving the patient a range of what it could cost, for example, being that, sure. So this, what I was referring to before is that I would give the patient, if you think it's possible, worst case scenario, it's going to be a 5-hour tummy tuck, give them the estimate for the 5-hour tummy tuck, and it's up to you whether you decide you want to collect for the whole 5-hour tummy tuck or you want to collect for the 3-hour tummy tuck. And then after the fact, if it does end up taking 4 hours or 5 hours, then you're legally able to send them a bill after the fact because it's no longer a surprise, as long as you included all that information in your good faith estimate. As an out-of-network provider, sometimes the insurance company will not tell us, okay, that's we've already addressed that. So do all parts of this law or just some apply to plans that are regulated at the state level? So yes, there were about 36 states that already had some type of surprise billing legislation already enacted. but they weren't as complete maybe as this. Like, for example, in California, it didn't necessarily apply to ERISA plans because that's more governed by federal level law. So the No Surprises Act, I can't go over all 50 states, but the No Surprises Act helped to fill in those holes where there may have been holes at the state level. And in certain circumstances where you'll have to check locally, the state law supersedes the federal law, is my understanding, in certain situations, if the state law was already strong enough and robust enough and didn't leave any loopholes.
Yeah, the No Surprises Act was intended to be a floor. That would be the minimal protections. If states go beyond that, then that's fine. And it also then gets into whether the state already provides a dispute resolution process. If it's as good, if it's better than the federal process, then the state process will control.
All right, and that was the last question. So I'm very pleased with how many people attended. Thank you so much for your attention. Again, you will get an email after this with the recording, but thank you all so much for your time. And if you have any questions, feel free to email me or Bob. Thanks again. Y'all take care. Thanks again, Bob. Appreciate it. Thanks to ASAPS.
My pleasure.